Interstitial cystitis bladder pain syndrome is often associated with vulvodynia and poor vaginal health. ICBPS causes pelvic and bladder pain and urinary symptoms, which considerably reduce the quality of life. To date, this condition has no definitive cure. Local estrogen therapy has been proposed as a treatment for vulvodynia and poor vaginal health to improve the symptoms of ICBPS. However, chronic local estrogen therapy could be contraindicated or not desired in patients. The present study reports the case of a 55-year-old postmenopausal woman with ICBPS who was successfully treated with combined vaginal erbium VEL neodymium ND YAG laser, VEL plus ND YAG therapy. The patient presented with a 5-year history of pelvic pain and urinary frequency. Direct approaches for the bladder such as hydrodistension, anticholinergic drugs, and transurethral Hunter lesion ablation cauterization were conducted with inconsistent results. Immediately prior to the patient's presentation, local estrogen therapy was administered for 12 weeks, however, this therapy resulted in mild improvement and poor patient satisfaction. After presentation, VEL plus ND YAG therapy was conducted once a month for 3 months. The patient reported considerable decrease in pain during urination. The improved symptoms were maintained for 6 months after the last therapy session. These results suggest that VEL plus ND YAG therapy is an effective method for improving symptoms in patients with ICBPS. A healthy, 55-year-old woman, Gravida 3 Para 1, body mass index, 26.2 kilograms, presented with a 5-year history of urinary frequency and pelvic area pain. She regularly experienced severe pain in the upper pubis throughout the day. Previous treatments, including lifestyle changes, various analgesic therapies, oral hydroxyzine therapy, anticholinergic therapy, selective beta-3 adrenaline receptor agonist therapy, intravesical DMSO injection, and transurethral Hunter lesion ablation cauterization, were ultimately ineffective. The patient was not receiving any antipsychotic drugs such as amitriptyline hydrochloride, had no history of pelvic surgery or photosensitivity, and underwent menopause at the age of 49. At a previous hospital, the patient underwent cystoscopic hydrodistension under general anesthesia. The bladder had dilated capillaries with hydrodistension at rest. Physiological saline was removed after 3 minutes, and post-distension mucosal hemorrhage, glomerular formation, and partial Hunter lesions were noted. Accordingly, the patient was diagnosed with ICBPS. Her pain returned 3 months after intravesical water pressure-based dilation. Immediately before presentation, the patient underwent transvaginal LET with estriol 0.5 mg. She reported mild improvements and overall dissatisfaction with the outcomes. 6 months after the last treatment at the previous clinic, she visited our outpatient office. Upon presentation, her pelvic pain and urgency frequency (PUF) symptom score was 22. The PUF includes 12 items divided into 2 domains, symptom and bother scores. The total PUF score ranges from 35 a maximum, severe problems to 0 minimum, no problems. No cystocele, rectocele, or dissensus was detected, and stress tests showed negative findings. Further, the Pap smear, urinalysis, urine culture, and urine cytopathology findings were negative. Based on vulvar atrophy and poor vaginal health, the patient was diagnosed with genitourinary syndrome of menopause. The patient's vaginal health index score (VHIS) was 10. In total VHIS, the range is between from 25 healthy to 5 poor. The patient reported vulvar spontaneous pain, and vulvar swab tests produced vulvar-provoked pain, especially around the urethra. In the uroflowmetry study, her maximum urine flow rate Qmax was 35 ml s, and voided volume VV was 110 ml, with no residual urine detected. Her 3-day urinary diary revealed that she urinated 40 times a day. Urination frequency was high when many genital and urethra-stimulating activities were performed, including sitting on a chair, riding a train, and doing desk work. In the cystometric study, the bladder was completely emptied using a catheter. A small, special catheter, which had a pressure-measuring manometer, was inserted into the bladder, and warm water slowly filled the bladder. Our patient reported the first desire FD, normal desire ND, and maximum capacity, MCC at 72.3 milliliters, 97.9 milliliters, and 110 milliliters, respectively. The patient complained of pain in the urethra, which persisted throughout the examination, when the catheter was inserted. During the cystometry, at MCC, she complained of severe pain in the bladder. The urethra was painful, but there was no strong sphincter or obstruction of the urethra. Based on the volume of water infused, VH2O and PVES at FD, ND, and MCC, the patient was not diagnosed with low-compliance bladder, which is defined as a significant increase in bladder pressure and a slight increase in bladder volume. In addition, despite urethral pain, detrusor overactivity was not observed. Cystoscopy confirmed hydrodistension at rest, and a random bladder biopsy revealed exfoliated epithelium with erosions, proliferative blood vessels, and conglomerations of submucosal inflammatory cells, diagnosed as severe stromal inflammation and Hunter lesions. The vaginal mucosal tissue was thin with few epithelial cells and blood vessels. After the random bladder biopsy, the patient chose to undergo 3 laser irradiations conducted once a month over 3 months. Follow-up was conducted 3 and 6 months after the final laser irradiation session. Bladder endoscopy and vaginal mucosal biopsies were conducted at T0 and T6 to confirm the therapeutic effects of VEL plus ND, YAG, and rule out malignant tumors as no cases of VEL plus ND. YAG therapy for the treatment of ICBPS have been reported. Bladder and vaginal epithelium thicknesses were measured at 6 random locations, and the average was recorded. VEL plus ND YAG therapy was conducted at an outpatient clinic. This laser setup is easily understood by Photona users. First, prepare the Laser Essentials, the cookbook for functional gynecology and aesthetics. This book was edited by Professor Gambacciani, Professor Gasper, and Professor Gaviria. There is a section which we wrote. Please, take a look at page 36 of this book. Here you will find a detailed description of the VEL setup. Next, please set up NDAG. If you want to check the settings, you can use the QR code to enter the article. Before the procedure, the patient's vagina was washed with an antiseptic solution and dried with a cotton swab. Renovelase Photona SP Dynamis, smooth mode protocol was used at a wavelength of 2940 nanometers. The laser spot diameter was 7 mm, frequency was 1.6 Hz, and pulse fluence was 1.75 JCM2, as previously reported, to prevent tissue ablation with a deep thermal effect. A specially designed glass vaginal speculum was used to insert the probe R11 into the vaginal speculum and avoid contact with the vaginal mucosa. After VEL therapy, NDAG therapy was conducted using an NDAG laser Photona SP Dynamis, piano mode, and R33 non-contact handpiece with a spot size of 9 mm, piano pulse mode 5s, and fluence of 90 JCM2. 6 passes were conducted in the brushing mode to treat the posterior commissure. The VEL and NDAG therapies were conducted during the same sessions with no gap between exposures to the 2 energies. The patient was advised to avoid sexual activities for 1 week following each session. We reported the efficiency of VEL for ICBPS in 2020. A total of 12 patients without improvement after several treatments before 2016 underwent VEL treatment, once a month for 12 months as per their convenience. The numeric rating scale 11 NRS 11, O'Leary-San interstitial cystitis symptom and problem indexes ICSI and ICPI, functional bladder capacity, and daily urinary frequency were obtained. In total, 9 patients responded to the treatment and 3 did not. The NRS 11 scores and ICSI and ICPI improved in all responders. The bladder capacity and urinary frequency also normalized. The residual effect lasted for 18 months from the first treatment without long-term side effects. At that time, we need from 10 to 12 VEL treatment per 1 year for NSAID-free. Professor Gambacciani reported VEL plus NDIAG treatment for superficial pain of vagina and vulva of GSM patients. 2 groups of sexually active PMW reporting superficial dyspareunia were selected, VEL group and VEL plus NDIAG group. Treatment consisted of 3 laser applications at 30-day intervals. Symptoms were assessed before, after each laser application and after 1 and 3 months from the end of the treatment, using the subjective VAS for superficial dyspareunia. Here, we described the effects of VEL plus NDIAG therapy in a woman with ICBPS who did not improve even after multiple conventional treatments. Nevertheless, this treatment resulted in improved vaginal and vulvar symptoms, as well as bladder symptoms. VEL plus NDIAG therapy can be a potential alternative therapy for patients with resistant ICBPS. Our report and literature review demonstrate the importance of evaluation of vaginal impairment and vulvodynia, and that of a minimally invasive therapy conducted around the bladder. Further randomized controlled trials and prospective studies are needed to elucidate the etiology and mechanisms of ICBPS.